Do this right now. Close your eyes, picture your morning pills, just once. Now pay attention to your mind. Do you feel a small blank space, a name that almost comes, then disappears? And if that fog returns after a new bottle, a dose change, or a nighttime pill, that is the pattern I want you to notice. It did not begin like an emergency. It crept in quietly. Maybe you forgot one appointment, then repeated the same question at dinner. Maybe you missed a familiar turn, left the stove on, or stood in the kitchen wondering why you walked in. Your family said, perhaps it is just aging. You tried more sleep, crossword puzzles, coffee, vitamins, or writing notes everywhere, but the fog came back. And each time, the fear became more quietly private. Here is what I need you to hear. Sudden memory fog is not random. It is not simply your age catching up with you. And it is not always solved by brain games or a stronger cup of coffee. Your brain does not lose sharpness, balance, alertness, and confidence for no reason, especially when a trusted medication has recently changed. And the most surprising part is this: the real trigger may not even begin in the brain disease people fear most. You may feel the symptom as memory loss, but the signal may be coming from a bathroom shelf, a pharmacy bag, a weekly pill organizer, or two ordinary bottles quietly adding up together. In my 25 years working with older adults, I have seen this symptom misunderstood over and over again. A sharp senior becomes foggy after a sleep aid. A caregiver notices confusion after a bladder pill. A family blames dementia before anyone reviews the list. I am not against medication. Many pills protect life. Today, I want to help you read that pattern. And we have science behind this. Researchers from the University of Nottingham in England, published in JAMA Internal Medicine, studied 58,769 people diagnosed with dementia and 225,574, matched controls age 55 and older. They found stronger dementia associations with several high anticholinergic drug classes. In simple terms, drugs that block memory chemicals can burden an older brain, especially when exposure is long or stacked. In this video, we will walk through 9 popular medication categories seniors must ask their doctors about before memory loss is accepted as normal aging. You will learn what to ask. Is this anticholinergic? Can it affect alertness, sleep, balance, or memory? Do I still need it? But I am not going to reveal the most important connection yet, because the real danger is what happens when two risks overlap. My name is Dr. Thomas Bennett. At Senior Health Daily, my promise is simple: calm doctor, led guidance, plain language, real research, and practical steps older adults can discuss with their own doctor. Before we go any further, drop a comment below and tell me this: is your memory change mostly forgetting names, misplacing items, or losing your train of thought? Because your answer to that one question tells me a lot about which pattern your doctor should review first. Write N for names, M for items, or T for train of thought in the comments. Add review if you will ask about your medication list this week. I read every single one. Now, one important point before we begin. Medication itself is not your enemy. It is part of your body's protection, comfort, and disease control. The problem begins when a drug sedates the brain, blocks acetylcholine, drains key nutrients, or combines with other pills that do the same thing. And after 60, that small burden can turn a mild side effect into daily confusion. So listen, because the first cause is the one many people miss, especially when the bottle looks harmless and the prescription has been refilled for years. Do not stop anything on your own. Bring every prescription, sleep aid, allergy pill, bladder pill, stomach pill, mood medication, and supplement to your doctor or pharmacist when the medicine cabinet is only the place where the warning quietly shows up. Before we name number 9, understand the biology. Your brain does not run on willpower alone, it runs on chemical messages. One of the most important is acetylcholine, the chemical that helps you stay awake, focused, and able to store new information. Think of acetylcholine like a light switch. When it works well, your brain can connect a name to a face. Remember why you walked into a room, follow a conversation, and stay steady at night. When that signal is blocked, the room does not go completely dark, but the light gets dimmer. After 60, that light switch is easier to disturb. The liver and kidneys may process and remove medication more slowly. Sleep may be lighter, blood pressure may drop more easily, and many older adults are not taking one medicine. They are taking 5, 7, 9, or more. So the question is not only, is this medicine safe by itself? The better question is, what is this medicine doing inside my whole body, with all my other medicines at my age. Medication-related brain fog can appear after a new bottle, a higher dose, a nighttime pill, a hospital stay, or a combination nobody added together. A senior may repeat a question, miss a turn, forget a word, sleep through the day, or lose balance. The family says, maybe this is aging. But a careful doctor asks, what changed first? A composite patient, I will call Margaret, 72, from Ohio, thought she was losing herself because she could not remember familiar names. Her daughter noticed the fog was worse after certain nighttime pills. When they reviewed the bottles and timeline with a pharmacist, the pattern finally had a name. Margaret stopped feeling blamed. Before we move into number 9, tell me your age and what city you are watching from. Are you watching as a senior yourself, as a spouse, or as a son or daughter caring for a parent? I am happy when you are healthy every day. I ask because this channel is not just information. This is where older adults and families can feel accompanied, learn more helpful knowledge, share openly, and feel happier every day. Number 9. The PM sleep and allergy pill that looks harmless. The first one may be sitting in the aisle marked allergy, sleep, cold, or nighttime relief. I am talking about first-generation antihistamines such as diphenhydramine, sold as Benadryl, Sominex, and many PM products, and doxylamine, found in some Unisom and nighttime cold formulas. Seniors take these because they are easy to buy, fast, and familiar. But ordinary does not always mean gentle for the aging brain. These drugs block histamine, which can make you sleepy, but they also block acetylcholine. When an older adult blocks that signal at night, the next morning may bring dry mouth, constipation, urinary trouble, blurry thinking, dizziness, or confusion. A composite patient, I will call Harold, 76, from Phoenix, used a PM pill whenever allergies kept him awake. His wife became scared because he asked the same breakfast question 3 times. Harold thought he was simply getting old, but the pattern matched the nights he used the pill. Now look at the data. The American Geriatric Society Beers criteria warns that first-generation antihistamines are highly anticholinergic, have reduced clearance with age, and increase confusion, dry mouth, and constipation. Yale researchers followed 426 hospitalized patients, age 70 and older, and found diphenhydramine was associated with a 70% increased risk of mental status changes and delirium symptoms. That matters. A sleep aid can create the very morning fog family's mistake for dementia. Ask yourself honestly, do you wake more confused after a PM pill? Do you feel hungover? Do you have dry mouth, constipation, blurry vision, or urinary trouble? Your doctor question is simple. Is this safe for my memory if I use it often? And does it add anticholinergic burden? If this first medication already makes you think about your own cabinet, type SAFE in the comments. One word, SAFE. Not because any pill should be changed alone, but because safety begins when you notice the pattern and bring it to your doctor. Do not stop or combine sleep aids without medical guidance. Number 8, the reflux pill that may calm the stomach while hiding nutrient problems. This one may calm the fire in your stomach while quietly raising questions your brain never gets to ask. I am talking about proton pump inhibitors, or PPIs, such as omeprazole, Prilosec, esomeprazole, Nexium, pantoprazole, Protonix, and lansoprazole, Prevacid. These medicines can protect people with severe reflux, ulcers, bleeding risk, Barrett's esophagus, and certain stomach dangers. This is not a stop your PPI warning. The hidden issue is long-term habit without review. Many seniors start a PPI after a flare. Then months turn into years. Nobody asks whether the original reason remains, whether the dose is needed, or whether labs should be checked. Stomach acid helps release B12 from food. When B12 runs low, a senior may develop fatigue, numbness, walking problems, mood changes, and memory difficulty. Magnesium balance can also be affected in some long-term users. A composite patient, I will call Elena, 74, from San Diego, believed her reflux pill had nothing to do with forgetfulness. She had taken it so long it felt like breakfast, not medication. Her doctor checked labs and reviewed the duration. Now look at the data. A Kaiser Permanente Northern California study in JAMA compared 25,956 people with vitamin B12 deficiency with 184,199 controls. Using PPIs for 2 years or more was associated with higher odds of B12 deficiency, with an odds ratio of 1.65. A neurology study from the atherosclerosis Risk in Communities cohort reported that people using PPIs for more than 4.4 cumulative years had a 33% higher risk of developing dementia during follow-up. The dementia evidence around PPIs is mixed, and association does not prove cause. The correct message is not panic. It is duration review, lab review, and benefit versus risk review. Ask yourself, did your reflux pill begin after a temporary flare and never stop? Have you had B12, magnesium, kidney function, anemia, or bone health reviewed? Your doctor question is, do I still need this every day? And should we check B12 or magnesium? If you are still that's sin. If you are still following at number 8, type number 8 in the comments. And if you do not like commenting, just type 0. That small signal tells me you are still here and that this careful medication review matters to you. Do not stop acid suppression abruptly. Review it safely. Number 7. The bladder pill many seniors are too embarrassed to question. This one is prescribed for a problem many seniors feel too embarrassed to repeat. I am talking about bladder antimuscarinic medications such as oxybutynin, Ditropan, or oxytrol, tolterodine, Detrol, and sulfenacin, Vesicare. Seniors take them for urgency, leaking, nighttime bathroom trips, and fear of accidents outside the house. That fear is real. Bladder control protects dignity. Some of these drugs calm bladder spasms by blocking muscarinic receptors. That can reduce urgency, but the same anticholinergic direction can burden the brain. The bladder may quiet down while attention, recall, and alertness become less sharp. A composite patient I will call Robert, 79, from Manchester, started a bladder medicine because he was afraid to leave the house. 2 months later, his son noticed Robert missed familiar turns while driving. Robert felt ashamed because the bladder problem was already embarrassing, and now his memory felt exposed too. Now look at the data. The University of Nottingham JAMA internal medicine study involved 58,769 dementia cases and 225,574 matched controls age 55 and older. It found stronger dementia associations for bladder antimuscarinics. A 2024 BMJ medicine study of 170,742 dementia cases and 804,385 controls found overactive bladder anticholinergics associated with dementia odds of 1.18. Oxybutynin, sulfenacin, and tolterodine reached about 1.27 to 1.31 in higher exposure groups. That does not mean bladder treatment is wrong. It means the brain must be part of the bladder conversation. Ask yourself, did brain fog start after a bladder pill? Are you also taking a sleep aid, allergy pill, antidepressant, or nerve pain medication? Do you have dry mouth, constipation, blurry vision, urinary hesitation, or new daytime sleepiness? Your doctor question is there a bladder option that does not block acetylcholine so strongly? If this calm, doctor-led guidance is helping you, like this video and subscribe now because every new subscriber strengthens this community for older adults who feel alone with confusing medication symptoms. The senior community becomes happier with useful health information because of you, and I am grateful. Every like helps this message reach another senior family that may need it today. Do not quit bladder medication suddenly without guidance. Number 6. The cholesterol pill that needs balance, not fear. This one is so common that warning about it requires balance, not fear. I am talking about statins such as atorvastatin, Lipitor, simvastatin, Zocor, rosuvastatin, Crestor, and pravastatin, Pravachol. These medicines lower LDL cholesterol and protect many people from heart attack and stroke. For many seniors, they are cardiovascular protection. So, let me be clear. Statins are not proven to cause dementia. Many studies suggest they are cognitively safe, and some research suggests they may even be associated with lower dementia risk in certain groups. But some people report memory symptoms, confusion, or brain fog after starting a statin, increasing the dose, or combining it with another medicine. That timeline should be discussed, not dismissed. A composite patient I will call Samuel, 68, from Toronto, read frightening claims online and wanted to throw away his statin. His brother had died of a heart attack, and Samuel was terrified of both heart disease and memory loss. His doctor slowed the conversation, reviewed the timeline, checked interactions, and adjusted safely. Now look at the data. The FDA added information to statin labels about generally non-serious and reversible cognitive side effects, such as memory loss and confusion, while still emphasizing cardiovascular benefits. A systematic review of randomized trials found no cognitive impairment signal in 14 studies with 27,643 participants. A newer review of 55 observational studies with more than 7 million people reported statin use associated with lower dementia risk, with a hazard ratio of 0.86, though observational data cannot prove protection. That is the balanced medical point. Do not blame every memory problem on a statin, but do not ignore a clear timeline after a new statin, a higher dose, or a possible interaction. Ask yourself, did the fog begin soon after a cholesterol medication changed? Are you also having muscle pain, weakness, sleep disruption, or new blood sugar concerns? Your doctor question is, could this symptom be medication related, and is this dose still right for me? Now I want to hear your personal story. Did brain fog begin after a new bottle, a higher dose, a nighttime pill, or a hospital visit? Write what changed first, what symptom worried you most, and whether your family noticed it before you did. I truly respect your story. Your story can bring real benefit to this senior community and may help another older adult recognize the same pattern sooner. Do not stop a statin on your own. Review first. Number 5. The anxiety or sleep pill that can become a morning trap. This one can feel like rescue at night and still become a trap by morning. I am talking about benzodiazepines such as alprazolam, Xanax, lorazepam, Ativan, diazepam, Valium, and clonazepam, Klonopin. Seniors may receive them for anxiety, panic, muscle spasm, insomnia, vertigo, or grief after a major life change. Short-term use can help in the right situation. Long-term use is where risk grows. These drugs enhance GABA, the brain's main calming signal. That can reduce anxiety, but it also slows reaction time, attention, balance, and memory encoding. The senior may not say, "I feel confused." They may say, "I feel unlike myself."
It's okay, sweetie.
A composite patient I will call
I'm right
Patricia,
here.
71, from Tampa, began lorazepam after her husband died. At first, it gave her the first calm night she had felt in months. A year later, she was napping most afternoons and forgetting bills. Her daughter thought grief had swallowed her personality. Her doctor did not shame her. They created a slow taper plan, added grief support, and rebuilt sleep habits safely. Now look at the data. The 2023 AGS Beers criteria states that older adults have increased sensitivity to benzodiazepines and that these drugs increase cognitive impairment, delirium, falls, fractures, and motor vehicle crashes. A BMJ prospective study found new benzodiazepine use associated with dementia risk, with a pooled hazard ratio of 1.46 across 5 cohorts. A French-Canadian study found Alzheimer's odds of 1.51, rising to 1.84 with higher exposure. That limitation matters too. Anxiety and sleep problems can appear before dementia is diagnosed, so these studies cannot prove every benzodiazepine causes dementia. But sedation, fall risk, dependence risk, and cognitive slowing are real enough that long-term use in older adults deserves careful review. Ask yourself, do you feel foggier the morning after taking it? Do you need more to get the same effect? Have you fallen, driven less, slept later, or stopped doing morning activities? Your doctor question is, can we create a slow taper plan or a safer long-term anxiety or sleep strategy? If this video could protect one spouse, one parent, or one friend from blaming memory fog on age too quickly, share it with them today. And turn on notifications, because this channel continues to bring useful medical guidance for older adults who want clarity, independence, and healthier longevity. Never stop benzodiazepines suddenly. Withdrawal can be medically dangerous. Number 4. The old antidepressant, nerve pain, or sleep pill that does too many jobs. This one looks like a do-everything pill, and that is exactly why seniors can stay on it for years. I am talking about amitriptyline, historically known by the brand Elavil, and related tricyclic antidepressants. These drugs may be used for depression, nerve pain, migraine prevention, sleep, bladder pain, irritable bowel symptoms, or chronic pain. Because one pill seems to help several problems, nobody questions it for a long time. But a multi-purpose pill can also become a multi-system burden. Amitriptyline has strong anticholinergic effects and can also be sedating. It can dry the mouth, slow the bowel, blur vision, worsen urinary retention, lower blood pressure when standing, and cloud memory. A composite patient I will call June, 78, from Auckland, used amitriptyline for burning nerve pain in her feet. She believed morning confusion was just poor sleep. Her pharmacist noticed that amitriptyline overlapped with a nighttime antihistamine. June was not dealing with one small effect, she was dealing with a stack. Now look at the data. The AGS-Beers criteria lists amitriptyline and several other tricyclic antidepressants among drugs with strong anticholinergic properties. In the Nottingham JAMA Internal Medicine study, high exposure to anticholinergic antidepressants was associated with increased dementia odds, with an adjusted odds ratio of 1.29 in the highest exposure category. A nationwide study of community-dwelling older adults found tricyclic antidepressant use was linked with more than twice the odds of falls or fall fractures, with an odds ratio of 2.13. That matters because many families notice the fall before they notice the fog. Ask yourself, are you taking amitriptyline for sleep, pain, headache, bladder discomfort, or mood? Do you wake groggy? Are you constipated, dry-mouthed, dizzy when standing, or more forgetful? Your doctor question is there a lower anticholinergic option for my pain, sleep, migraine, or mood? Do not stop antidepressant or nerve pain medicine suddenly. Number 3. The antidepressant that sounds gentle but has a senior-specific warning. This is the one I warned you about earlier because it sounds modern, gentle, and harmless. I am talking about paroxetine, sold as Paxil or Pexiva. It belongs to the SSRI family, a class many people think of as newer and cleaner than older antidepressants. But paroxetine is different from many other SSRIs because it has stronger anticholinergic properties. A person may be taking it for depression, panic, anxiety, hot flashes, or sleep-related distress, while the older brain receives another acetylcholine-blocking burden. It may also be sedating. In a senior already taking a bladder pill, sleep aid, or nerve pain medication, paroxetine can become one more brick in the wall. A composite patient, I will call Denise, 69, from Liverpool, started paroxetine after panic attacks following a hospital stay. It helped her anxiety, but later her family noticed she seemed emotionally flat and forgetful. Denise was afraid to mention it because she did not want panic to return. Her doctor reviewed the full picture and changed the plan slowly. Now look at the data. The AGS-Beers criteria includes paroxetine among medications with strong anticholinergic properties. A study of elderly nursing home patients with depression emphasized paroxetine's strong anticholinergic and sedative properties and concern for adverse cognitive outcomes. The Nottingham study also found anticholinergic antidepressants as a class associated with increased dementia odds at higher exposure levels. The safest message is not never treat depression. Depression itself can harm memory, sleep, appetite, social connection, and heart health. The safest message is choose the long-term treatment that fits both mood and the older brain. Ask yourself, did emotional flatness, sleepiness, word-finding trouble, constipation, dry mouth, or confusion appear after paroxetine? Has the prescription continued for years without a benefit review? Your doctor question is this the safest antidepressant for someone my age? Before we reach the final 2 warnings, make sure you are subscribed so your future questions do not get lost in silence. Then leave the question you most want a doctor to explain deeply. Is it about sleep medicine, bladder pills, antidepressants, drug interactions, memory testing, or how to talk to your doctor without feeling dismissed? I promise I will read every comment, and I truly value this senior health community because your questions show me what older adults and caregivers are facing in real life. Do not stop paroxetine suddenly. Withdrawal can be intense. Number 2, the antipsychotic sometimes given for sleep, agitation, or restlessness. This one worries families because sometimes the person taking it does not even realize what kind of drug it is. I am talking about antipsychotic medications such as quetiapine, Seroquel, risperidone, Risperdal, olanzapine, Zyprexa, haloperidol, Haldol, and similar drugs. These medicines can be necessary for schizophrenia, bipolar disorder, severe psychosis, dangerous agitation, or carefully selected situations. But in older adults, especially those with dementia-related behavior, they require a serious risk-benefit conversation. The hidden problem is that these medicines are sometimes started during a crisis and then quietly remain. A hospital infection, a nursing home transition, A week of agitation. A period of dangerous sleeplessness. The medicine may have made sense in the moment, but the reason for continuing it should still be reviewed. A composite patient I will call Arthur, 82, from Glasgow, received quetiapine after severe nighttime agitation during an infection. Months later, the infection was gone, but the medication remained. His daughter noticed he no longer laughed at breakfast and walked as if his body had become heavier. She asked the right question, and the prescriber reviewed the original reason. Now look at the data. The FDA warning for elderly patients with dementia-related psychosis was based on 17 placebo-controlled trials showing drug-treated patients were about 1.6 to 1.7 times more likely to die than placebo-treated patients. The AGS-Beers criteria warns that antipsychotics increase stroke, cognitive decline, and mortality risk in dementia. A large BMJ study in adults with dementia also linked antipsychotics with higher risks of stroke, venous thromboembolism, heart failure, fracture, pneumonia, and acute kidney injury. This is serious. It is also not simple. Sometimes risk exists on both sides. Severe agitation, hallucinations, danger, or psychosis can harm the patient and caregiver. Ask yourself, was this medication started during a hospital stay, nursing home transition, infection, fall, or crisis? Is the person sleeping more, walking slower, speaking less, or seeming emotionally distant? Your doctor question is, why was this started? Is it still necessary? And what is the shortest safe plan? Do not stop antipsychotics abruptly. Review with the prescriber. Number 1. The stacking effect nobody adds together. The most dangerous one is not a single bottle. It is what happens when nobody adds the bottles together. This is anticholinergic polypharmacy and cognitive burden. A senior takes diphenhydramine for sleep, oxybutynin for bladder urgency, amitriptyline for nerve pain, paroxetine for anxiety, and maybe a benzodiazepine after a stressful hospital stay. Each bottle has a reason. Each prescriber may be trying to help, but the brain experiences the total chemical load. A composite patient I will call Leon, 81, from Chicago, had 3 specialists and 1 urgent care visit in 6 months. Nobody was careless. Everyone treated a problem. But no one saw the full stack until his daughter placed every bottle, patch, inhaler, cream, supplement, and over-the-counter product in one bag. The pharmacist identified duplicate sedation and anticholinergic burden. Leon's doctor changed the plan slowly. Now look at the data. The University of Nottingham study found that overall dementia odds increased from 1.06 in the lowest anticholinergic exposure category to 1.49 in the highest category, compared with no anticholinergic prescriptions, nearly 50% increased odds with high cumulative exposure. The adult changes in thought study in JAMA Internal Medicine followed 3,434 older adults and found that the highest cumulative exposure to anticholinergic drugs was associated with a dementia hazard ratio of 1.54 compared with non-use. That does not prove every case is caused by medication, but it proves the total load deserves attention. When several drugs block acetylcholine, the senior may develop dry mouth, constipation, blurry vision, urinary retention, sleepiness, confusion, falls, and memory trouble. Your doctor question is, can you calculate my total anticholinergic burden and review every prescription, over-the-counter pill, and supplement together? The pattern is simple. Number 9 was the sleep or allergy product. Number 8 was the stomach pill. Number 7 was the bladder medication. Number 6 was the cholesterol pill. Number 5 was the benzodiazepine. Number 4 was the old multi-use antidepressant. Number 3 was paroxetine. Number 2 was the antipsychotic. Number 1 was the total load. For 1 week, write down pill time, fog time, sleepiness, bowel changes, dizziness, falls, missed turns, repeated questions, and new confusion. Bring original bottles when possible, because bottles show dose, timing, refills, and ingredients. Call a doctor urgently or seek emergency care if memory change is sudden, severe, worsening quickly, or linked with one-sided weakness, facial droop, trouble speaking, chest pain, fainting, fever, head injury, severe dehydration, hallucinations, severe agitation, abnormal sleepiness, or a fall. This video is education, not a diagnosis, and not permission to stop medication on your own. Now for the practical action plan. Tonight, gather prescriptions, sleep aids, allergy pills, stomach pills, bladder pills, pain pills, mood medicines, vitamins, herbs, patches, creams, eye drops, and inhalers. Tomorrow, write 3 columns: medicine name, reason you take it, and what changed. This week, schedule a medication review and ask, before we call this dementia, can we review cognitive burden, anticholinergic burden, sedation, dose duration, and interactions? For 2 weeks, track 1 trigger: nighttime pills, morning fog, or new dose days. Long-term, ask with every new medication, how will we know if this affects my memory, balance, or alertness? Tell me what topic you want me to explain next. Safer sleep options, bladder medicine questions, antidepressants after 60, medication interactions, or how to prepare for a pharmacist medication review. I use your topic requests to choose future videos that answer what this senior health community truly needs. Now let us correct a myth. Coffee does not cancel medication fog. Vitamins do not erase anticholinergic burden. Brain games do not fix a sedative stack. Changing the time of day does not always solve the problem if the medicine itself is too sedating or too anticholinergic. And natural supplements can still interact with prescriptions. The safest home remedy is not a secret drink or a miracle capsule. It is a complete medication list, a written timeline, and a serious review with someone trained to see interactions. The danger is not one medication by itself. The danger is assuming memory loss is age before the medication list has been reviewed. Some drug-related confusion, fog, sleepiness, and unsteadiness can improve when the cause is found early and the plan is changed safely. Before you accept rapid memory loss as dementia, ask your doctor whether a medication, a dose, or a hidden drug combination could be part of the problem. Please do not forget to subscribe, because I have a related video coming soon that continues this warning system. In that video, we will look at body signals beyond the medicine cabinet: sleep changes, balance shifts, walking speed, hand changes, and energy patterns families miss until the problem becomes harder to reverse. This is the natural next step after today's medication review, and it is one older adults and caregivers should watch.